Good morning. While my colleagues are coming up here, and you guys sit on that side, please, just so you're not blocked by the podium. My name is Jenny Andrews, and I am really excited to look out and see all of you here today. I am the Executive Director of Malaria Partners International, which is the host of this event. So it is a true delight to see you all out there. I'm really excited because I do know, by the way, that we are the only thing standing between you and a break. So we're going to be fast and we're going to be fun. And I'm excited to introduce some people that I've worked with for many years on the project that Dr. von Bierbrouwer just mentioned, Partners for a Malaria-Free Zambia. These folks are all headquartered in Lusaka, and I'm just going to start really briefly with some quick introductions. First of all, Martha Lungu. She is the Executive Director of Malaria Partners Zambia, which is she really focuses on finding community-based interventions and having Rotary clubs get deeply engaged with that kind of work. She's got well over 10 years of experience in this kind of work, but prior to this, she was a certified public accountant. So she brings a lot of data analysis and accountability to her role. She is a phenomenal, inspirational woman, and I think you will really enjoy hearing from her. Todd Jennings was a colleague of mine when I was working at PATH. Todd is the team lead for policy and communications at PATH. He's also lived in Lusaka for 18 years, I think, and raised his family there. He brings 2 decades of experience to health communication, advocacy, and strategic partnerships. And Todd is one of those people who's able to really translate a lot of the complex public health data into stories that even people like I can understand. So I've always appreciated Todd for that. And finally, I'm really excited to introduce Eric Liswaniso. Eric is a new generation of malaria warriors, and he is the programs manager for Partners for a Malaria-Free Zambia. And as Dr. von Bierbrouwer said earlier, Partners for a Malaria-Free Zambia has now graduated and become part of Rotary Healthy Communities Challenge. So both Martha and Eric are still involved very heavily on a daily basis in that work. Eric has a lot of experience. He's got a master's degree in project management and has done a phenomenal job. He is a committed malaria warrior and truly an emerging Rotary leader within the malaria world. So please help me welcome. Martha is going to come up here first. So welcome Martha Lungu.
Okay. You know, when you're used to making presentations and you just say, next slide, please. So, where do I place? Okay. Oh, is it a green one? Thank you very much. It's indeed a pleasure to be here on the panel alongside Eric and Todd, where we're going to share our experiences working with community-led malaria initiatives. To start with, the scaling of the malaria projects in Zambia begins with a journey on the Copperbelt. That is the mining area of the Republic of Zambia. And we started with the Copperbelt Phase 1 project, where we trained, equipped, and deployed 301 community health workers in integrated community case management. I know most of you are so technical and familiar with ICCM, but basically it's the training of community volunteers to test, diagnose, and treat malaria within their community And it's integrated because there's malaria, pneumonia, and diarrhea. And so that's what we did on the Copperbelt Phase 1 project. Then we went to Copperbelt Phase 1A. So here we trained 200 community health workers. And in case I forgot to mention, the Copperbelt Phase 1 project was supported by the Rotary Club of Ndola Mukuba as a local club. And then the international club was the Rotary Club of Federal Way. Then the Copperbelt Phase 1A, the host club was the Rotary Club of Kitwe. The international club was the Rotary Club of Aspen. So we trained 200 community health workers in a town called Chililabombwe on the Copperbelt. Then we moved to Copperbelt Phase 2. This was a big one. So 3 Rotary clubs came on board, being the Rotary Club of Mofolira, the Rotary Club of Kalulushi, and the Rotary Club of Luansha. Then as local clubs, then we had the Rotary Club of Seattle number 4 as the international club. So in this grant, we trained a total of 1,055 community health workers in the 3 districts I mentioned. And so when the opportunity for the programs of scale arose, we were scaling, as Excel already alluded to, the Copperbelt projects where we already had community volunteers testing, diagnosing, and treating malaria, pneumonia, and diarrhea within their communities. So fortunately for us, we were awarded the first ever programs of scale, and it being a $2 million project, we had partners like World Vision, the Bill and Melinda Gates Foundation coming on board, and it became a $6 million project. So under the Partners for a Malaria-Free Zambia project, we trained a total of 2,500 community health workers across 10 districts in 2 provinces, that is Central Province and Muchinga Province. And Axel had the opportunity of visiting Muchinga Province, very bumpy, but I think he survived. Though he was asking for a flight back, it was really, really rough. But then, so that's how hard getting to these hard-to-reach places can be. Then we, as already mentioned, we are now undertaking the Rotary Health Communities Challenge, which is a $30 million project and is across 4 countries. Zambia has been awarded $5 million. And in this grant, again, we're working with World Vision and PATH as co-implementers in 2 provinces, in 6 districts. And we are training, equipping, and deploying a total of 2,086 community health workers. So grounded in the foundation I talked about was a strong theory of change that resulted in the deployment or the taking of primary health care to the doorsteps of the community. I think you agree with me that malaria kills when treatment is delayed. And in most cases, treatment is delayed not because somebody wants to delay the treatment, but only because the access to the closest health facility is so far. And we've heard stories where the closest health facility is 40 kilometers, 60 kilometers. It's very hard to walk that distance, even when you're okay. Now imagine a person with malaria walking 40 kilometers to access primary health, to access care. It's not easy. So you see people will just give up. And those who are lucky, they would give them roots, leaves, and for some reason, some will survive, but the unfortunate ones would die. But then what this program is doing is taking the care just to the doorstep. So you don't need to walk 40 kilometers. You just go to the neighbor and you get tested. If you have malaria, you are quickly treated. And I know you're going to ask, so if malaria deaths are not being recorded in the areas where we have deployed these community health workers, unfortunately, the answer is yes. Why? You know, it's one thing to deploy a community health worker, but it's another thing for people to go and access that care immediately. For malaria, time is of the essence. So prompt care is very important. That's what makes the difference between life and death. I'll give you a personal example. I lost a son in 2020, and the hospital to my house was just a thrown store away. Yeah. Yeah, exactly that. You'd just walk. It was a 2 minutes, 3 minutes walking distance. And because he delayed to get tested and treated, we lost him. Not because the system was not working, not because there wasn't care, but because we delayed. Like I said, for malaria, time is of the essence. I just thought I'd give you this quick synopsis of our genesis. And I'm here to respond to how scaling worked in Zambia. And for starters, we align our work with that of the National Malaria Elimination Strategy and also the Ministry of Health strategy. So the community health worker or integrated community case management program is very much part of Ministry of Health. And then secondly, we don't go it alone. We work in partnerships. We work with other organizations that have the same vision as ourselves. Then data-driven action. So we have PATH as one of our partners that are technically savvy to this data management. And when you have data, correct data, it also enables you to make well-informed decisions. I think this is also why it has worked for us. Strong local ownership. So we work with traditional chiefs, traditional leaders, civic leaders, as well as faith-based leaders. We work within these community confines, and they buy in the project, and they become part of the project. Continuous learning. So we learn, we adapt, we improve, and I'm happy that it's not just us in the project who are learning. So we also have other players like the example that Axel just shared with us, who are also learning, adopting, and innovating where need arises. It wasn't smooth running, frankly speaking. We had our own share of challenges, and among the challenges was the commodity stockouts, especially during the COVID-19 era, where the concentration was so much on the supply of COVID commodities. Malaria was neglected, and so the little gains that we had, we started losing those gains. Geographical barriers, I mentioned that even now, we still have the hard-to-reach areas in Zambia that are completely cut off, especially during the rain seasons. We know these community health workers are supplied commodities by the Ministry of Health. They still need to get to the health facility to collect their commodities, but then there are times, because of geographical barriers, they are not able. So this is also another challenge. Then community health worker motivation. We know they are volunteers. We know they have given their time to help in the community, but they still have families to feed. They still have to take care of their own businesses. And in most cases, the business I'm referring to in communities like the ones I'm talking about here is they need to plow the land, they need to grow and take care of their families. But then because they have to stay at home and attend to their community members who would want to access care from them, so they are neglecting the other part of their life. In conclusion, how did we survive despite all the challenges? And by the way, those are not the 3 challenges, but major challenges. But then the question is, how did we survive? Persistence, yes. We stayed the course despite disruptions. Secondly, partnerships, I talked about already. There's a saying, I know I'm going to mess it up again. They say, when you walk alone, you walk faster, but when you want to go further, you walk in a group. Something like that, yeah. Yes, and then community voices matter. Yes, the people most affected, like I said, we are part of the solution. So we involved the community leadership. Then again, alignment and intent matter more than flawless execution. So then lastly, we measured, learned, and improved, and again, we used what we had to create what we needed. So it's really been a journey. If I was told to use one word, I would say transformative, and thank you very much.
Thank you, Martha.